Ramesh sir?
Yeah, Shweta.
So good afternoon. Puri
Good
sir has joined. We'll start. Can I start with the introductions right away?
Sure, yes.
Yeah. Kiran sir, can you please start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is LAC, LAC Plus and provision of second line and third line ART. And the speakers are Dr. A.K. Puri and Dr. Ramesh Alam. Dr. A.K. Puri is currently the Deputy Director General at NACO, and Dr. Ramesh Alam is working as the Public Health Specialist with CDC India. So we welcome you both to today's NDLS session and request you to address the session. Puri sir. Puri sir, with your permission, can we start the session, please?
Sir, you're on mute if you're speaking, sir.
Ramesh sir, I'll check with NACO.
Sure, Shweta.
Okay, Acha.
Yes, sir.
Now I am unmuted. Yeah. So I'm sorry, I could not listen to the announcement from your end. This is Dr. A.K. Puri.
Yes, sir.
Am I audible?
Yes, sir.
Yeah. Actually, at that time, probably it was not. My system was, there was some system problem in the system, so it has been taken care of. So this is Dr. A.K. Puri, DDG CST. I welcome all of you to this very important session. And in this session, we will be learning about the LAC plus centers and how the provision of second line and third line ART is being done, and their standard operating procedures. So flow of PLHIV at the LAC and how to provide the services will be explained in details in this session. PLHIV who are failing on first and second line drugs, and how they will be put on the higher line, means these first line, those who are failing on the first line, they will be put on the second line. Those who are on failing on the second line, they have to be started on the third line. And for this, the patients are referred to the SASAP. And so each and every detail will be shared with you. So you will be understanding what is the process of referral. You can also give your suggestions that how to improve this. I mean, further, there are certain day-to-day issues which PLHIVs are facing. You can give your input on that also, how to improve and how to reduce the out-of-pocket expenditure, how to reduce the queue, how to improve the queue management. This is also can be, this suggestion can also be given by you also. And accordingly, we can also make some changes in the SOP. In this session, we will also be talking about the various tools and formats which are used to capture patient information, etc., and recording, reporting of the data, and roles and responsibility of various staffs of LAC, LAC Plus, and the SASAP will also be there in today's session. So over from my side. Now, it is over to the moderator. Thank you.
Ramesh sir, you are requested to please continue the session.
Yeah, thank you, sir, for your kind introductory words. With this, we will be starting our session on the LAC and LAC Plus, and also provision of second and third line antiretroviral therapy. Good afternoon, all. As part of the continuation of this operational guidelines dissemination, you already heard about the ARD initiation process, then follow-up. Then we also heard about what are the differentiated service delivery models. So in this session, we will focus mainly on one of the key differentiated service delivery models adopted by NACO, that is the Link ART and LAC Plus centers. So these are pertaining to our guidelines. These are Chapter 5 and Chapter 6 of the operational guidelines that we have currently with us. The model of Link ART centers, as you know, is a differentiated service delivery model that was actually implemented through 2008. And the key aim of this Link ART centers was to provide decentralized, patient-friendly services to minimize the travel and waiting hours and the cost towards the patients. So LACs were initially set up at our public health facilities. Those are at the district and the sub-district level, usually co-located or within the ICTCs. Now, the change that you see is that the current guidelines also have a provision of expanding this location of Link ART centers within the community dispensation sites, such as the opioid substitution therapy centers, the prisons, the care support centers, targeted interventions, and other NGO or CBO or CSO-led interventions. So now we are expanding our LAC, LAC Plus locations from just the physical structures of a public health facility to also these community-driven sites where the communities are more congregated and more decentralized at their doorsteps. Once we know where we are expanding in these current guidelines, next we also will have to see what are these pre-ART care. For example, the Link ART Plus centers that were actually established were in 2011, mainly for the pre-ART care. Now we know we are implementing treat all policy. So with that, the scheme is now revised to expand the scope to include ART initiation. That is, the Link ART centers, the Link ART Plus centers will start initiation of antiretroviral therapy within their centers itself. And please look into the rider, that is Link ART Plus center shall be authorized to initiate ART after a written approval from NACO or SAC. So there is a disclaimer very clearly within the guidelines that these have to be approved by NACO or SACs for initiation of ART at Link ART Plus centers. And we will see further how to do this. So the objectives of this Link ART or Link ART Plus center is to increase the access to ART for PLHIV and to improve drug adherence and retention. As we know, the challenges of adherence and retention, one key challenge is the travel expenses, the expenses or the wages that the person is losing to attend an ART refill at the ART centers. And possibly also he or she will not be able to maintain or sustain that when the patient is on this lifelong antiretroviral therapy. Now, to bridge the gap between the testing and the treatment services also. So if you have a treatment service somewhere and ICTC somewhere else, there is also a loss in patient referral that we have seen in the last session. This is the first step of loss that we are seeing. That is a patient from ICTC to ART center if there is no linkage, and that is the first linkage loss that is happening. So in order to bridge this gap, these LAC plus initiations would be further enhancing that opportunity for early ART initiation. Then to integrate HIV care and treatment services within the general health systems that we are seeing now within a sub-district hospitals, or we can also have these sites within the CSO settings. And to increase the involvement of community in retention of PLHIV. This is how the expansion of the vision of this LAC Plus has now percolated into the closed settings like prisons or into other areas where we have a community-led cargo models that are being part of the national program now. With this, we come to the functions of LAC. So what are the key functions? As most of you know, it is for drug refills that for stable patients that are accessing services here. And we also want to monitor these patients during every pill pickup that they are coming to this Link ART for OI prophylaxis, if somebody is still requiring OI prophylaxis, or screening of PLHIV for symptoms, which happens for every visit of the patient to the healthcare provider. That's what the guideline says. And if there is any miss or any LFU within those patients who are registered in the LAC or LAC Plus, and psychological functions. More or less, these are the functions that you see for an ART center too. Now, apart from the functions that we just have discussed, look at the 9th point, that is back referral to the nodal ART center as specified criteria at every 6 months or earlier if required. So this again becomes a very critical role. We see currently within the program that usually patients are not being referred on time for a CD4 count or for a viral load. So this is where we again have to emphasize our LAC Plus centers to refer back our patients who are stable at Link ART for monitoring of their treatment to the ARTs, to the nodal ART centers for CD4 and viral load. And if you look at the functions of the LAC Plus, in addition to the LAC, the important functions that an LAC Plus needs to perform is to enroll PLHIV for ART initiation, ensuring the baseline investigations are done through the institution where the LAC Plus center is located, and referral of symptomatic patients, that is, who are clinically unstable, to the nodal ART for ART initiation. That is the initial time if the LAC plus cannot initiate patients on antiretroviral therapy because the patient is unstable. And a very clear note that you are seeing here is the LACs at the community-based sites, that is either at the closed settings or CARG models or at the CSCs, other than the hospital setup, may not have a doctor or a paramedical staff there. Such facilities should refer PLHIV with any adverse symptoms or 4S positive to the nodal ART for consultation, diagnosis, and management. So this again is very important as we are setting up the LACs within the community, CSO run facilities, what all we have described just now. There we do not have a medical staff. So any suspicion of an OI or the patient is not doing well should be referred to the nodal ART center immediately. Now, how an LAC can be set up? So here, now, as you go through this session, you have to understand that when we talk of LAC, we are not just looking at LACs that are to be established within the public sector setting, but also within the community settings, which we just described. So link ART centers, whenever they need to be established, number one is we need to see whether there is a significant number of positive cases detected at ICTC within that catchment area. So we need to review the last 5 years data and see if there are more than 100 patients coming within that locality. Then we could think of starting an LAC there. And ART centers where the patient load is very high. We know some centers are catering to 3,000, 4,000 or having a footfall of 200 patients per day. So they need to look into to decentralize some of these patients nearer to their location. And one of that could be whether the positivity at the next site is higher. Then long distance of patients who are residing and longer time. If the public transportation is available, if it is taking longer time, then we need to look into establishing an LAC. The districts where they do not have an ART center. So sometimes we have situations in states like UP where we do not have an ART center per district. So there again, we need to look into how better to expand our link ART centers in order to enhance retention among patients who are on ART. Then the above criteria may be relaxed for those sites that are not within the ambit of the public sector facilities. And also where the difficult terrain, hard to reach areas such as hilly regions, desert, tribal regions, closed settings. So these are all, there are certain relaxations that we could have, putting the
Dr. Ramesh, I'm sorry,
Ramesh,
we could not hear you.
Yeah, please give us 2 minutes, ma'am. I think he has a network issue.
Okay.
Yeah, sorry. Hear me?
Yeah, it's so you'll have to share your screen again. Yes, it's visible. Full screen mode, please. Yeah.
Now, so this is where how we need to set up the link ART centers. Then what you see next is what are the requirements again for setting up these sites in a health facility that is within the most probably in the public sector hospitals. We need to have a space for LAC, at least one room where we need to accommodate possibly the drugs, the patient records, everything. So this is one important thing within our public health facilities. Then the staff at the LAC, as you know, the LAC staff or the LAC should be actually utilize the existing human resources of the facility, and no other additional manpower will be provided there. The same guideline continues here, that we need to utilize the staff from the institution where the LAC is planned to be set up. That is, we need a doctor there. The health facility should identify 2 to 3 doctors, at least 2 of them. One of the doctors among them shall be the LAC in charge and day-to-day functioning of the activity within the LAC and reporting to the nodal ART center. Then the counselor at the ICTC shall bear the responsibility of counseling these patients, because one key important responsibility of the link ART is psychological function, and to ensure that the counseling is given every day for retention, every visit, sorry. And then a staff nurse at the facility again should depute a nurse to assist the doctor and coordinate with the counselor, where again she would be helping in terms of core symptom screening during every patient visit. And pharmacist, one of the pharmacists in the health facility should be identified and be responsible for the drug storage, dispensing, and drug record keeping. And a computer literate will be preferred, because we also need to again put in these drug dispensations that we have done in SOCH. So all the above staff will be trained by NACO or SACS on structured LAC curriculum at identified training centers, which will be seen in the next slides. And the LAC facility assessment should be done using the standard format that is part of the guidelines. Now, once we know who are the staff responsible and how to set up an LAC, we can see a very good flow of events for setting up an LAC. So the activities, as you know, for the first identification of the prospective LAC site, we have seen. Just to recapitulate them, we need to have greater than 100 patients at least. For a crowded ART center, we could plan the access to an ART center if it is not within the same district. And we could also look into some congregate settings or other CSO settings. So all these should be taken up by SACS and during the proposal of the annual action plan. Then we receive an administrative approval of after we include this plan from NACO. Then a meeting between the SACS and the DAPCO and the civil surgeon or the medical superintendents of these hospitals will be undertaken. And an approval letter will be shared with an LAC from SACS to set up with prior information from NACO. And the training will be organized at the facilities designated by NACO, where CST officials, regional coordinators, if present for the state, or by the CST division of NACO, will be undertaken for trainings. And what we are looking at is a 2 days hands-on orientation for the whole LAC team with all the medical officers, staff, nurse, and all at the nodal ART center. And it will be the responsibility of the CST officials within the state and also the regional coordinators where are present. And provision of recording and reporting tools from the concerned SACS will be taking place. And operationalize of the link ART centers and monitoring of these will be taken care by the CST officials of SACS, nodal ART, LAC in charge, and also DAPCOs where are present. So this is the setting up within our public health facilities. Now, what if we are planning to set up link ART centers within the CSO or the TINGOs or an OST, or you have in a closed setting like in prisons? What do we do is, for setting up these, the eligibility criteria, as we have seen, there will be a relaxation after approval from SACS with intimation to NACO. And the LAC at these community sites shall not have any additional financial implications to NACO or SACS, and can be set up based on the needs of the PLHIV, even outside the annual action plan after approval of the SACs with intimation to NACO. So what this means is, if suppose there is a felt need after an AAP is approved, and this was not part then, but still there is a possibility where SACs could actively engage NACO in this and get the requisite approvals to start this LAC out of the public health sector facility. And based on the need of the community, we could set it up. So all other steps for setting up an LAC are the same that you have seen, getting approvals, training, all these are the same things. And how to upgrade an LAC to an LAC Plus. As you know, the LAC Plus scheme is rolled out at the existing Link ART centers within the health system only, where you have a load of more than 70 PLHIV on ART, and this needs a prior approval from NACO. And these centers are provided with an additional staff nurse to assist in carrying out the functions of LAC Plus. Now, the criteria of upgrading an LAC into an LAC Plus would remain the same, and the scope of LAC Plus, as you know, is being expanded to include ART initiation and follow-up, which requires an approval from NACO and SACs, while we continue to do our progress towards initiating patients on ART at the LAC Plus. Only the LACs within the health system will be upgraded to an LAC Plus. So this is one thing that we need to remember. Not all the LACs that are set up within the COC, within the CSO's setting or at any other sites will not have this opportunity to be scaled up to a LAC Plus or upgraded to an LAC Plus. The scope of the LAC Plus, as you know, we have to remember now in the current guidelines, ART initiation is part of it, and this requires a prior approval and an assessment by SACs to actually start this ART initiation process. Now, the additional staff at the LAC Plus, you know that a staff nurse will be provided by NACP to the LAC Plus centers that are approved by NACO. And what will be the qualifications? The first preference is a BSc staff nurse with the working knowledge and skills on computer is very essential now with the introduction of SOCH into the program at the LAC and LAC Plus level. And if the staff nurse with BSc is not available, the GNM will be maybe appointed, and the remuneration will be at par with the NACP norms. And who will do the recruitment will be carried out by the administrative head of that facility where the LAC Plus is approved. And for CD4 sample collection and transportation, the existing laboratory technician of the ICTC shall be utilized. All above staff again will be trained by NACO or SACs on the structured LAC curriculum at the identified training sites. So now how to upgrade an LAC into an LAC Plus? Very important thing, how many patients is the 70 number of patients to be at the LAC. Only then an approval process for upgrading that will be shared from SACs to NACO during the AAP. Once approved, then appointment of the staff nurse by the DAPCO or the district nodal officer of HIV concerned facility. And then training of the staff, as we have seen in the earlier slide, will be the responsibility of NACO SACs and the regional coordinator. And orientation of the whole team again, provision of monitoring tools by SACs, and operationalization of the LAC Plus. So this is the flow of events that we need to keep in mind while we want to start. But the key important thing will be to have patients who are at least 70 PLHIV, then to have a yes or an approval from NACO as part of the AAP is another critical step. Then the district administration will be responsible for appointment of the staff nurse at this LAC Plus, which is approved, and the monitoring tools should be provided by SACs with a training component to them. And guidelines for LAC Plus functioning, as you have seen, should be examined all the patients for both LAC and LAC plus, the patients should be examined at the general OPD time on all working days within the OPD time. So we cannot have a fixed day for these patients to come. On all the days that that facility is open, that is that hospital is open, and the LAC shall follow the same holiday as per the health facility where you are located, where the LAC plus is located or LAC is located. And the timings, all working days in the community setting should be decided in consultation with the community and SACS or DAPCO. So this is very important. If we are setting up an LAC within the ambit of the community, then we need to take the community, hear them, and based on their convenience and timing, and also the CSO where it is being implemented or the facility where it is being implemented within the community, we need to take a consensus and then put up the timing and the working days for the LAC within the community set. And the link ART will be utilizing the computer which is already available within the facility for entry of all the SOJ and other entries that are to be made to the nodal ART center or to the SACS for reporting purposes. And we should ensure that there is a broadband internet connection. Now, the information regarding LAC or the LAC plus working hours, services available, emergency should be displayed at the LAC prominently along with the details of the nodal ART center. So this again is very important that the patient needs to understand when he can come there and what is the nodal ART center for him to go back. So all these should be displayed at the link ART or the link ART plus center. Once we know how to set up a link ART center and how frequently we should be opening the center and what are the guidelines for an LAC and LAC plus, now we come into what are the standard operating procedures we need to follow for patients who are already on antiretroviral therapy at LAC or LAC plus. This is not for initiating ART at LAC plus, but for already patients who are there on ART at these two sites. Now, the key term that you have to remember all through is link out. So eligibility criteria for link out, when I say that is patient being referred from a nodal ART center to the link ART or link ART plus center is called as link out. You are basically linking out a patient from an ART center to an LAC plus center. So that is called as link out. Now, who are those patients eligible? We have already seen in our first and second sessions, prior sessions, of a stable criteria. So all stable patients, PLHIV and CLHIV on ART for at least 6 months without any OI. So these are the, and the criteria remains the same here for the stable clients. And very important thing is the definition of stable patient should be applicable to patients on any regimen. So if a patient who is on third line or second line is stable, even those patients should be referred to an LAC or an LAC plus if the patient is seeking. So this is another very important thing which is not part of the previous guidelines. And the other thing, if a patient is on TB preventive therapy, that is if a patient is on IPT prophylaxis for tuberculosis, for prevention of TB, should that patient, can the patient be linked back, can that patient be linked out to an LAC or LAC plus? Yes, that is, a patient should be stable on ART. Along with that, at least the patient should have completed 3 months of TPT, that is TB preventive therapy, can be linked out. But after being linked out, proper counseling, adherence, adverse effect monitoring, and also screening for 4 symptoms will continue to happen at the link ART or the link ART plus center. Now, very important thing is we have been hearing that patients at link ART center are also stable And so they should not be deprived of getting their multi-month dispensation also. Just because the patient is at an LAC or LAC plus and we know that the patients are stable, why should they be coming every month to the health facility? So they should also be offered multi-month dispensation after thorough review of any barriers to adherence or their commuting to that place and any other disclosure issues. All that should be taken care before we put a person on multi-month dispensation. PLHIV with a poor adherence to ART may be linked to an LAC in order to enhance retention. That is, we know that what we are saying is a patient should be stable and should have adherence prior to being stable. So one of the stable criteria is also looking at the adherence of the patient. So sometimes this adherence may be affected just because he is not able to travel so long, and the solution for the adherence is the patient should actually be closer to his house while to get his ART every month. If that is the solution, such case-by-case basis patients, we may be linking out to a link ART center in order to improve or provide a solution for his non-adherence, or you want to increase the adherence of that patient to ART. So this can be done on a case-by-case basis. Now, the prescription of ART. Once the patient, it has been decided the patient is ready to be linked out to a link ART, the nodal ART center, the responsibilities that need to happen there at the ART are counsel the PLHIV and provide all information about LAC and dispensation and that the patient has to undertake. And prescribe ART for 6 months to the PLHIV before linking out, who would be provided drug refills at the link ART. So this should be told very clearly to the patient that we are giving a prescription. Based on this only, the LAC will be dispensing the drugs to you. You will not be getting different drugs at that place. Again, getting an experience from all of you and also from my side was part of some of the link ART center visits to an ART center. What we hear most commonly from the patient is patient will have is anxious when we say that you can go and get your own drugs at your link ART. They may be, most of them are apprehensive that they are going to get different drugs or substandard drugs at a link ART center. So we need to re-emphasize and tell the patients that they are going to get the same drugs there. When they are going to get linked out, the prescription is going to be the same thing. And we are also going to give that 1 month drugs before he actually reaches that link ART center. And only for designated persons linked to that ART should be linked out to that LAC plus. So every ART center will have designated link ART centers and link ART plus centers. Only that patient needs to go there. You cannot get multiple ART centers referring to that side because it becomes very difficult while we report back to the ART centers. So there will be one nodal center that will be referring to that particular link ART center. And one ART center can have multiple link ART or link ART centers, but the referral will only happen through that particular nodal ART center that is linked to. Now, the nodal ART center shall report about the total patients linked out to the link ART center in the monthly ART reporting format, that is in the NPR. And LAC will not initiate or modify ART in any patient at any point of time at the link ART. So this is very important for the functionaries at the link ART center. And also this should be told to the patient that this cannot happen at the LAC. What are those documents that a patient needs to be going with, or we need to ensure before link out should be sent to the LAC or LAC with the following document. That is, patient should be linked out to the LAC through the IMS or the SOCH that you have. And there is no need to maintain any link out forms that we were actually having earlier, but now we do not need that because we are linking actually through the SOACH or the IMS platform that we have. And the prompt will go to through the IMS to the LAC wherever the PLHIV is linked out. And we need to give patient the original patient booklet or that green booklet with the details of link out, address and contact details of that LAC, and 1 month drugs along with the patient. And the white card to be maintained at both the centers marked as an LAC copy and ART center copy. The card to be updated based on the information received from the nodal ART center, LAC or the LAC Plus. So the key things that we need to remember here are, earlier we were following link out forms. Now we do not have that link out forms, but updation in IMS and or SOACH is very important now, because that will erase a prompt within the SOACH to that center wherever the referral is going out or link out is happening. And we need to ensure that the patient is carrying the green book along with the copy of the white card and 1 month drugs along with the patients to ensure that there is no way the link out is going to hamper any ART interruption. Now, how to ensure and what is the drug availability that we need to ensure at these ART centers? So, at the link ART centers. Ideally, at least 3 months of stock should be available for PLHIV at LAC or LAC Plus at any point of time. That is, if 100 patients are there, we need to ensure that there are drug stocks for 100 into 3. So many months of drug stock should be available. For LAC, number of linked out PLHIV that is alive and who are missed from the nodal ART center into 3 months plus 1 month of buffer stock. For LAC Plus, in addition to the above, we also have to receive drugs for PLHIV who are newly initiated on ART. That is, when we are calculating this, we need to ensure what is the average number of PLHIV per month into 3 plus 1 month of buffer stock. While we calculate, the important thing that we need to bear in mind is we are also planning for, or there are certain states already are doing multi-month dispensation for patients on link ART or link ART Plus. While calculating the stocks, don't forget these patients who are on multi-month dispensation while we calculate the stocks. Now, how the drug transfer takes place, this again is very important because we see a discrepancy in drug stocks just because we are not updating in SOACH, or this information is reported twice at both the facilities. So how to minimize all these errors and ensure stocks are correctly monitored is based on the calculation that we have seen in the prior slide. ARV drugs will be supplied on quarterly basis, or even if required earlier, the pharmacist who is at the nodal ART center will cross-check with SOACH and recommend for approval by SMO in charge of the ART center. So a verification process will be done by the pharmacist at the nodal ART by looking at IMS or the SOACH, and then drugs may be transferred to link ART through the LAC staff or by the health system staff or the vehicle or through a courier agency, whatever is the current mechanism of the supply chain that we have within the state or from the nodal ART, that will be one of those categorized into one of these. And the cost of the transportation will be borne under the operational cost provided to the nodal ART center or the recurring grant of 20,000 given to LAC or LAC Plus in public health facilities only. And the TA or DA for the contractual staff involved in the drug transfer shall be given as per NACO or SACS guidelines. And to the government staff, it has to be as per the state government rule. So these are all set norms that we have and the operational costs that we know. So this is how the transportation of the drugs will happen from the nodal ART center after verification by the pharmacist, approval by the medical officer, quarterly, or the tranche can be even transferred even earlier but engaging either any of the current mechanisms, and the reimbursements will happen as per the rules that we have just seen. Now, drug stock reporting is another very critical element, which I just said. The nodal ART center shall not deduct the total quantity of drugs transferred to the link ART center in the monthly report that is being sent to NACO. It should not be deducting the total quantity of drugs, because that is the consumption of the ART, and when you're reporting to NACO, the LAC patients are part of this MPR. So if you deduct them, if you deduct the drugs, you will have 100 patients being under your ART center, but only if there are 25 of the LAC patients in that, you are reporting in the total number, and you deduct the drugs, it will show as there are 100 patients, but only 75 patients are getting drugs. Something like that, you will have a discrepancy if you're actually deducting the drugs. So that should not happen. And it should only deduct the drugs actually dispensed to the patient at the LAC during the month as reported in the monthly reporting format of LAC to the nodal ART center. So this is the thing that we need to ensure. And the IMS or the SOCH entry should be happening by the pharmacist of, sorry, it's not NACO, by the pharmacist of the nodal ART center to report the stock in SOCH as soon as the stock is given to link ART. So the LAC staff should be updating the dispensation in SOCH on daily basis. LAC in charge should physically verify the stocks of all ARVs every month to cross-check with IMS and MPR and sign in the stock register. So this is all to ensure very good systems within this LAC, so that we do not have any stockouts coming out, even though there are stocks available at the nodal ART center. Now, what are the services at the link ART or the link ART Center Plus that we need to have for patients who are already on ART? To recap the things, PLHIV, whoever is enrolled in the ART should be enrolled in the ART register. Once the patient is enrolled in the register, a new white card shall be maintained at the LAC. The data is entered in SOCH, and the same physical examination that we do for examination of weight, asking the patient for adherence, adverse events, and OI by the medical officer, information to be recorded in the ART register, white card and green book, drug refill. So this is the flow of events or the services that we give at the LAC or the LAC Plus centers for patients who are already on ART. Now, if you look at the flow, the same thing, that is, we need to first register the patient at the OPD as per the requirement of the health facility. So every health facility, depends on where it is, will have some norms on how the patient should be registered at the OPD counter. Then we fill the ART enrollment register and a new white card at the LAC or LAC Plus. An examination of the LAC at the LAC by the medical officer, general OPD. There will be no separate OPD again for LAC. That's what we have to visualize now. And then the drug dispensation by the pharmacist. White card is again retained at the LAC, LAC Plus. Computerization of the patient data by counselor or staff of the staff nurse in IMS. So this is all the flow of patients who are already on ART at a LAC or LAC Plus. Now, the guideline we are going to look at is the patient's dose table will be linked to a, or going back from a link ART center to the nodal ART. This is called as linking in. That is, a referral back is termed as linking in. Link out is from the ART to the to the link ART or the link ART Plus center. And linking in is referral back to the nodal ART. So the patient shall be referred back to the nodal ART center in the following conditions. So one is routinely every 6 months, once in every 6 months. Now, why we are referring back or linking back these patients is to repeat viral load testing if required, CD4 count, or we want to have a comprehensive clinical review, or for any a package of investigations which are not available here, which are required as part of the patient follow-up. So for all these, we need to routinely refer the patient back to the nodal ART. Now, please ensure that the patient should be sent at least 1 to 2 weeks prior to the refill due date to the nodal ART. Now, the referral slip should be given at 5th month itself and explained accordingly. So this is very important. Don't do it at the 6th month. It is 6 months referral. We need to be very sure that the patient is referred or reaching that center within the due date. Give them the due date prior and ensure that the patient understands that he needs to come back again once these investigations or a comprehensive review by the medical officer at the nodal ART center is done. So this again, there is a lack of information or understanding by the patient that he has to return back. And referral before 6 months, and you also may have to refer the patient in between, just not waiting for every 6 months, but you may have to refer in between. So what are those instances when we will be referring the patient prior to the 6 months period is if TB or any other OI is diagnosed or suspected, if there are any major adverse events of antiretroviral drugs in the patient, if the patient is pregnant and if it is required, unstable, or if the patient is not putting up to the appointment dates or missing drugs and non-adherent. For LAC outside the health facilities, PLHIV who are 4S positive or have any other major OI or an adverse event should be referred. So these are all some of the instances where we should refer the patient to the nodal ART even before that 6 months routine visit that the patient has to be going to the nodal ART center. This is all called linking in. Now, how to document that link in? Now we have seen how to document the link out. How to document? When the patient is referred back to the nodal ART center, he or she should be given the following documents for follow-up at the nodal ART center. So the patient should be linked into the nodal ART through SOCH. Again, earlier guidelines, we had a link-in forms too. Now there is no link-in form, but this has to be done through the IMS or through SOCH. So prompt will be generated again in SOCH to the ART center whenever the patient is linked in at the ART, nodal ART center. Original patient green book with details of LinkedIn should be again provided to the patient. Now, once the patient is reaching the nodal ART center, either because of the routine 6 monthly referral, or there are instances of an opportunistic infection or any other things that we have seen in the previous slide, the following activities will be again done at the nodal ART center. There will be a good clinical and a thorough comprehensive physical and clinical examination, post-symptom screening, and referral for viral load or CD4 count, or any other routine investigations that are required as part of the guidelines. Review or modification of the drug regimen if required, and whether the PLHIV visits the ART either for 6 months or so, there should be a drug refill should be done by the ART center for the month. So be very careful. Whenever a patient is coming to you to the nodal ART center as a link in from the LAC or LAC Plus, ensure that we are giving again that next month's drugs to the patient. don't expect the patient to go back to the LAC or LAC plus to get his next pill pickup. So the drugs should be given to the patient by the nodal ART center while referring back. This again, there is a bit ambiguity in this particular guidance. So I want to again reiterate that once a patient reaching the nodal ART center, whenever he is being linked back to the link ART center, linked out to the link ART center, we need to ensure that once drug is being given to the patient by the nodal ART center only. Now, what are some of the standard operating procedures for ART initiation? And I want to draw everyone's attention on the call now. The LAC Plus guidelines have been expanded to have ART initiation at the LAC Plus, but this will happen with the prior approval of SACS or NACO only. But while we get these approvals, I will walk you through the guidance, how we need to start this process whenever we get the approval, and how to think about this process while the patient is, while the center is looking for initiations. Please look at this algorithm. Once patient is detected positive at the ICTC, patient will be enrolled in HIV care at the Link ART Plus Center, which happens even if you are initiating or non-initiating. The patient is getting referred here, and on the same day, we do the screening for opportunistic infections using the NACO algorithm, which again was explained to us in the first session, and STI and other comorbidity, WHO clinical staging, all this is being done. And we register the patient in the register. A white card is provided and a green book. Once we have done this thorough clinical examination, trying to document everything within the ART register, the white card and the green book, we will have a situation to put or categorize the patient as symptomatic or asymptomatic. Now, when can we categorize the patient as asymptomatic? So a patient coming to the link ART, at the link ART plus, the medical officer at the link ART has examined thoroughly and is categorizing the patient as symptomatic or asymptomatic. Now, if a patient is categorized as symptomatic by the physician at the link ART plus, further diagnosis and management before ART initiation is required, either at the LAC plus, or you refer this patient to the nodal ART for ART initiation and management. The second part is, if the patient is categorized as asymptomatic by the physician at the LAC Plus Center, ART preparedness counseling, address verification, identification of the caregiver, CPT prophylaxis, if it is indicated, will be done to this asymptomatic patient at the LAC Plus. ART initiation, if the patient is prepared for adherence for lifelong antiretroviral therapy, and enroll him or her in the ART register, that is ART enrollment register, and follow up this patient every month, assess for side effects, every visit for adherence and TB screening, and reporting in the IMS or in the SOCH will happen. So to summarize this slide, when can a LAC Plus Center initiate ART? Number one is having a physician at that site who will do a very thorough clinical examination, refer to all the baseline investigations, and then have categorize the patient into symptomatic and asymptomatic. If the patient is symptomatic, refer the patient to the nodal ART, or under the guidance of the nodal ART center with requisite diagnosis and management of OIs will happen at the Link ART center under the guidance of the nodal ART, and initiation will happen at the nodal ART center. If the patient is asymptomatic, same things of preparedness counseling, ensuring adherence, screening for OIs, documenting in the ART register, preparing the patient for lifelong ART, identifying the caregiver, and at every visit ensuring a follow-up, again reviewing the OIs during every visit will continue to happen as he is in the ART center. Now, HIV, now one thing what we have to remember is, here we need to get the ART number or the HIV care number from the nodal ART center. We cannot generate, the Link ART Plus center cannot generate an ART number or a HIV care number there. So what should happen is the HIV care number can be only generated by the nodal ART telephonically in SOCH after registering the PLHIV in the HIV care register, even at the nodal ART center. One copy of the white card should be maintained by the nodal ART center after issuing a HIV care registration number for that patient. And patient tracing in case of LFU and preparedness phase shall be done at the LAC Plus. So there were some questions coming even before the session related to this one, that how to generate a HIV care number. So this will be done in consultation with the nodal ART in the SOCH, and also this number will be part of the nodal ART center's register, that is pre-ART or ART register, and then the follow-up will be happening at the LAC Plus center, and the white card will also be generated at the Now, for baseline investigations, they should be done through the mechanism available within the general health system. The staff nurse shall refer the patient for baseline as recommended by the medical officer. Blood samples for CD4 will be taken again at the LAC Plus, shall be collected on a prefix day and sent to the nodal ART center. Now, the ICTC LT or the staff nurse will draw the blood samples on the same day. And this is a one prick that we will be doing for both basic investigations and the baseline CD4 count. Now, the sample for CD4 test will be sent to the nodal ART and other baseline to the health facility. And baseline workup of all PLHIV for ART initiation and to rule out other OIs shall be done at LAC Plus as per the technical guidelines. And if the facilities are not available at LAC Plus, the investigations may be done at the nodal ART center. So this guidance, again, what we need to ensure is fixing up a date for CD4 count with the nodal ART or the center which is linked for CD4 count, picking up this one prick for both complete baseline investigations and for CD4, and sending or transporting the CD4 sample. So these are all very clear and which are currently being part of the National Operational Guide. So this again is the flow of events. Just to recap, first we ensure ART preparedness counseling, and the date of initiation will be recorded in the HIV register and the patient white card. When the baseline reports are available, PLHIV reports who are normal and who are asymptomatic, they will be called back to the Link ART center, LAC Plus center, and the MO needs to make necessary adjustments in the ART regimen. And information related to the registration and initiation of PLHIV and LAC shall be shared weekly with the nodal ART center through IMS. Only the nodal ART center will issue an ART plus number after enrolling the PLHIV in the ART enrollment register. Patients initiated at LAC would be followed up on monthly basis at the LAC for treatment or for laboratory monitoring. So this again becomes a routine that what we have seen in the previous slides for 6 months referral or in between whenever there is a need for referral to the nodal ART center. And link out for nodal ART, these are the same things that we need to remember. Referral of PLHIV to the nodal link ART center. Now, PLHIV who cannot be initiated on ART at LAC plus shall be referred to the nodal ART by adding details in IMS. In HIV care register under remarks column, staff nurse will record the status as referred to nodal ART. This is very important because we want to ensure that the patient is reaching the nodal ART center for ART initiation if it was not possible at the LAC plus center. Okay. And then when the patient is referred to the nodal ART center for management or for ART initiation, should be given the following documents for follow-up at ART. Patient should be linked into the nodal ART center as we have seen in the previous slides, and the original green book or the white card. And what are the reporting and tools that are to be maintained? In addition to those tools at the LAC, here we need to have a HIV care register for LAC plus. This is the same register that is being followed at the ART center, only because we are also planning to initiate patients on ART here, a CD4 sample transport register, a HIV TB register in the line list. Then IMS or SOCH at the LAC plus monthly report. IMS login shall be created for each LAC and LAC plus for entry of PLHIV to monitor drug dispensation. That is the reason why we are saying if there are any new centers to be set up, the pharmacist and the staff nurse, wherever we are picking up, should be literate with the computer. Nodal ART center staff shall conduct an orientation of LAC staff on IMS and will assist in supportive supervision. Regular drug dispensation or refilling will happen. And due to unavoidable circumstances, if IMS entry is not possible, if it is not possible at LAC, then need to be continued as we are using previously the 4B and the 4C forms. So this again becomes very important. Now we have seen the capacity building. Please focus on this slide. The capacity building, how it should be done for LAC and LAC plus. Now the normal LAC and LAC plus, if you look at the medical officer, there are 2 days of training, and the venue will be at the NACO designated training centers or the COEs. And participants will be LAC in charge, LAC medical officers. And if it is counselors, again, there is a 3 to 5 day duration training. And the LAC or the ICTC counselor will be attending. And we also discussed about the hands-on orientation of the LAC team that will happen at the nodal ART center, and it is for 2 days. For LAC plus staff nurse, it is a 5-day curriculum again for the LAC nurse, and it will again happen at the NACO designated sites. And hands-on orientation also will be part of the team orientation of the LAC plus. This will happen at the nodal ART center. Now, please remember the hands-on training of the LAC team will be done at the nodal ART and coordinated by SACS or DAPCO. However, rest of the training programs can be facilitated by SACS or nodal ART center officials. With this, we come to the end of chapter 5, and we will be starting chapter 6 now. Mostly the guidelines have changed in terms of 2 or 3 important things, and I want your attention here for provision of 2nd and 3rd line antiretroviral therapy. We know that patients who are suspected ART failure or who have severe adverse effects and complicated clinical cases are referred for review by a panel of experts called SASEP, that is State AIDS Clinical Expert Panel at COE or the ART Plus centers for further evaluation and timely switching. Now, SAC should develop a linkage plan for all ART centers in the state by mapping the functional SASEPs. And linkage plan should be based on the patient's convenience to travel to the SASEP if required. In case SASEP is not able to handle the increased caseload, new ART centers should be proposed by SACs to NACO. And each COE or ART Plus center will have defined ART centers attached to it. So this we know, but the very key important role that we are giving now is expansion of ART Plus centers if the SASEPs are, the present SASEPs are not able to handle the requests or referrals that are being sent by the ART center. Now, how to constitute a SASEP? The program director of the COE or the nodal officer of the ART Plus will propose a group of experts or faculty from the institutions where the COE or the ART Plus is constituted. And it will have a program director or a deputy program director for the COE and nodal officer of the ART Plus center. One or two additional faculty members, preferably from the Department of Medicine or allied departments. We also can include the external ART experts from other government facilities, if necessary, or private institutions, the regional coordinators, technical experts, joint directors, a pediatrician from the institution shall attend if there are CLHI. The SM or the MO of the ART center should attend the SASEP. At COE, the SASEP coordinator, research officer, nutritionist, and the data analyst will also be attending the SASEP meeting. At the ART Plus centers, this is important. Counselors on rotation will take the role of SASEP coordinator, staff nurse, and the data manager should also attend the SASEP meeting. The schedule is SASEP meets weekly to review all cases referred in that week and backlog, if any. It meets on the next working day if the designated SASEP day happens to be a holiday, and a backlog of, if it is very high, they may meet. Even the frequency can be increased. Now, the functions of SASEP, as we know, would be reviewing and deciding on the substitution of appropriate alternate regimen, mentoring the linked ART centers to ensure high quality case management. The SASEP will also look into the correct and complete documentation of the referrals and also monitor the progress of the patients that are being on alternate or substitution or switching drugs. Identify the operational issues of the attached or the linked ART centers and share the results over email and phone within 1 week of receiving e-referral from ART. And monitor those patients who are substituted or switched in the subsequent SASEPs. So this is the critical role of SASEP to ensure timely switching or substitution of drugs. Now the SASEP review, what are the standard operating procedures? When should a patient be referred to a SASEP? Whenever there is a suspicion of an ART treatment failure, or there are adverse events or adverse drug effects to decide the substitution of any one or more drugs, when there are certain complications or management issues of OIs that cannot be managed at the ART center, and patients from private sector who are coming with different regimens that are not part of the program for an opinion of the most suitable regimen. So these are some of the critical instances where we should be referring patients to SASEP, and decision of initiation of the third line shall be taken by the SASEP at COE or select ART Plus centers after e-review. Now, very important thing to note in the current guidance of the guidelines, the NACO is specifying that after the SASP has reviewed the patient and prescribed third-line ART, initiation and follow-up dispensations would be done by the parent ART centers as is being done for second-line ART. Henceforth, transfer out for initiation of third line is not required. This is very important. Now, the mechanism is e-referral to SASP. That is the patient treatment guidelines. What is meant by e-referral is all the patient treatment details, that is ART history, viral load, serial CD4, adherence, all these should go to the SASP with the RRF form from the referring ART. Now the SASP will review would be conducted in absence of the patient. Recommendations of the SASP would be shared with the referring ART. But please note that in certain circumstances, SASP may want to review the PLHIV in person. So patient visits the centers on these designated SASP days for clinical consultation. Preferably, inpatient review should be done for PLHIV belonging to the same COE or ART plus where SASP is being conducted. So what this means is, if suppose there is a center or COE is for example, if there is COE Gandhi, so patients from Gandhi ART center as much as possible should be reviewed in person. SASP. Following the e-referral procedures described above, ART center and the ART plus would be virtually connected over video or teleconferencing to that ART center, and ART center will present cases to the SASP in presence or absence of the patients, and SASP gives recommendation for further course of action. So the difference between this e-referral is e-referral, what we are talking is the referral of RR form and the decision of the SASP, everything happens. Now, tele-SASP is after the e-referral pattern of all the documents that you have done, virtually the COE or the ART plus SASP is connected with the medical staff at the referring nodal ART center for them to have a discussion on the cases that are there. This can happen with the patient at the node referring center or without the patient. So there is a communication that is happening over the SASP with the referral site. So what happens with this is there are benefits of these tele-SASP is to reduce the turnaround time for SASP review, need for multiple communications between ART, giving appointments. All this is not required once this tele-SASP is part of the intervention. Now, how to determine treatment failure? We know that patients with less than 1,000 copies or target not detected are virally suppressed. The action is to continue same treatment, and next viral load will be as per guidelines. And not suppressed is greater than or equal to 1,000 copies. And then we have to have an enhanced counseling. After that, we need to ensure at least 3 months of 95% adherence. Then repeat viral load. After that, if a patient is having less than 1,000 or TND, continue same regimen, or else refer to SASP. So that is how we need to interpret the viral load results and do. And in exceptional cases with high viral load and poor clinical outcomes, ART medical officer may refer the patient for further management, even on the basis of a single viral load. So this is important. Case by case, the medical decision can be taken. In patients with HIV-2, decision of ART failure is taken based on the immunological failure criteria only, since we do not have a mechanism to have a viral load for HIV-2 patients. Now, how to refer the patient to SASP? The first important thing is to ensure that you have all the details completed on ART history, clinical staging, T-staging, treatment adherence, series of CD4s, and the next step will be the SASP coordinator at COE or the data manager at the ART plus shall download the patient information and prepare SASAP meeting format for review during SASAP meeting. In case of teleconsultation, referring ART center should be informed in advance about the date of SASAP to call the patient by the SASAP coordinator or the data manager. SASAP will review the documents in absentia, make recommendations. And the step 4 is SASAP coordinator or the data manager shall share the recommendations. And step 5 is referring ART center to inform the action taken to SASAP by filling RRF. This is very, very, very important. The step 5 usually doesn't happen after after a recommendation is given by the SASAP also will want to know whether that is implemented, not implemented, challenges, and follow up on that. So the SASAPs will also ask the centers, and it is bound that we send a status update from the referring ART center to the SASAP on the action taken based on the recommendation provided by the SASAP. And you heard of NASEP, that is National AIDS Clinical Expert Panel, is a mechanism to respond to the queries raised by the SASAP of COA and ART+. The functioning of NASEP is coordinated by NACO, and this panel has representatives from ART Technical Resource Group of NACO institutions, experts deemed most appropriate for query under consideration. The composition is actually dynamic and it will be varying. Most of the NASEP work is done through e-consultations, and you can note the email ID nasep.naco@gmail.com. And what are the reporting tools and recording tools that we have for SASAP? One is the SASAP referral and reply form, that is the RRF form, which is you can find in Annexure 13. The referral form to be generated and filled in IMS to be used for referring patients. And then you see that the ART center needs to send this, and then you get entries in the IMS. The second one is the referral summary line list, which is again a revised one. There you have the referral summary for second or third line and list of patients referred to SASAP for review during the financial year along with the recommendations of SASAP. This you find as an Annexure 3. And SASAP register, which again has columns generated for list of all patients referred to SASAP to review, along with the recommendation of the SASAP and action taken. So, and this is to be maintained at all SASAP of ART Plus or COEs. This may be generated automatically from IMS. So this is only a soft copy that you will be having. And the last is the SASAP meeting format for second line patients. This format should be prepared before all SASAP meetings for all patients, children and adults, reviewed in the particular meeting for suspected treatment failure. This is to be prepared from SASAP register in IMS before every SASAP meeting, given to all members during the meeting. Printout of the soft copies should be taken in separate ring bind folds that we are currently doing for every year. So there will be not many hard copies of this. These are mostly the soft copies that will be generated from the IMS or that can be abstracted from the data that you already have from the RRF form. Thank you all for your patient hearing, and if there are any doubts or some chats that we could discuss. I know we overshot the time, but thank you. Yeah.
So can you please allow me to share my screen?
Sure.
Few questions, sir, which have already been addressed. If I can take them again. A patient can take MMD from LAC. Can a patient take MMD from LAC?
Right. So yes, the patient can take MMD from LAC. That's what we are seeing. He should not be deprived just because he's at an LAC, not at a nodal ART center. Again, the criteria is the same. Ensure that you have the follow-up details, the phone number, everything updated, ensure that all the barriers of adherence or disclosures are actually told, look whether the patient can store the drugs, all the same things can be done, and MMD can be given to patients at LAC or LAC plus.
For how long can we issue drugs on in-transit patients?
Transit basis to PLHIV to any other center. How long can we issue drugs? Okay, if you're transferring out a patient from ART center to a link ART of that same center, that's what we are saying.
No, Dr. Ramesh, can I come in here? So I think this we would discuss in the subsequent sessions, but dispensing the drugs on transit basis by the new center is just a temporary or an interim arrangement in COVID times or in difficult situations. So as a program, that is not encouraged as a policy that every time you should be giving drugs to the transit patients. And if the patient has shifted the locality, then he should be encouraged to take transfer out from the previous center and then get a transfer into your new center. But we will discuss this in more details in subsequent sessions.
Thank you. Thank you.
There have been reported some issues in SOCH related to dispensation summary, proper reporting, and date of next visit, which is not shown right in the SOCH.
Thank you for bringing this, and I think you have informed SACS and NACO about this. You will be getting some solutions for this one. And do LAC or ARV provision is to be made only at SOCH enabled institutions as per current scenario. When actually an LAC or LAC plus is being approved, you are given a number, a link ART number to that. So what the current guidelines or what we follow is, yes, the dispensation should be happening with enabling the IMS details or the SOCH details to the LAC for correct reporting.
Can I just add in here? So I will say this has to be other way around. So wherever you have an LAC or LAC plus, you should ensure that the SOCH ID is created for that link ART center and it is being implemented. So first set up a link ART center, and then as part of the guidelines, SOCH or IMS ID should be created.
Can one ICTC refer to other ICTC directly where LAC plus is functioning? Okay, you have an ICTC where there is no LAC or LAC plus. If you want to refer directly to an LAC plus center.
Yeah, that possibility can be there, but then the jurisdiction area for link ART plus center has to be decided by SACS. So whenever a LAC plus center is established and they are authorized to do ART initiations, SACS would also be telling the ICTCs like which ICTCs can directly refer the patients to a LAC plus center.
Who will make SOCH entry of the new registrations done at LAC plus when the HIV number is obtained from the nodal ART? So it is a staff nurse who will be, because in the data manager module, or that module will be done by the LAC plus staff nurse, and then the dispensation details will also be done at the LAC plus. Is that the question?
Rishi ma'am has already answered this.
Yes, I think, yes, Dr. Ramesh, I think you answered it.
Yeah, just give me a minute. So I'm checking the chat box for additional questions. Can you elaborate more on LAC in community setting?
Okay, so now we have, like we heard in the previous session about the differentiated care models. That is, where all we could establish decentralized dispensation sites for the benefit of the community, or because of areas that patients cannot travel so long. These are called as community cargo models. Or if you have more number of patients within a prison setting and it is difficult to dispense drugs to them. So currently we are dispensing drugs there at these sites. So we need to ensure that they are now called that they are link ART centers now. Dispensation is happening, decentralized dispensation. You're bringing CD4 count, the viral load, everything is happening at those sites. But first they need to be have an approval as a link ART center there. Now the difference between both these is these centers mainly look into decentralized dispensation. There is no much monitoring of a clinical person is not there every time at these settings. So that's what we have clearly told that if there is a suspicion of even a minor OI or any adherence issues, immediately these patients will be referred to the nodal ART center. But in a setting where we have in the public sector, there we know that there is an institution, that is the link ART is part of a healthcare facility. So you have people to actually attend to their clinical needs. That is one difference. The second thing at the community level is they also have to be recognized as an LAC because these drug dispensations that are happening like the public sector LAC run will also be done there and they will be notifying it. So these are only very minor subtle differences. And the third difference is all criteria will not be the same as a link ART center criteria. As we discussed, there will be some leeway given there because they may be set up in very hard to reach areas. They may be set up in a prison setting. So there you may not have everything very stipulated that we are seeking in a healthcare facility.
Yeah, just to add here, Dr. Ramesh, so basically, because till now, NACO was just approving the link ART centers for public health facilities, but it has been realized that some of these patients, they are regularly going to some of the community settings like CSCs or TI NGOs, and where they prefer to get the drugs. So that's why to bring all these facilities where patients prefer to get drugs, they have been brought into the ambit of link ART centers, and they are supposed to follow the standard protocols for link ART centers. And they would be like for official purposes, they would be registered as LAC so that reporting and all the SOPs are streamlined and standardized across.
Right, yeah.
Thank you, ma'am. So the next question is about issuing drugs to patients on second and third line ART at the LAC. Should the drugs be issued for 3 months?
Right. Again, as we have told, as the guidelines have clearly noted, that all patients who are stable, even first line, second line, if they are coming to the ART center, and we are also giving multi-month dispensation, the same thing will be followed at the link ART center too, irrespective whether they are on second and third line. The same criteria for follow-up, stringent follow-up, and adherence monitoring should happen.
Okay, so one more question. How can private center or NGO refer any patient for opinion?
For opinion?
Opinion, yes.
So
Okay,
we'll take up this in next session.
Yeah.
Dr.
Okay,
Ramesh.
okay,
We have an
Correct,
exclusive
correct.
session on referrals.
Yeah. Can I unmute the participants for maybe 10 minutes now? Can we take up?
Yes. Sure.
Participants can unmute their mics if they have any questions.
Hello, this is Dr. Samina here, Dr. Reshu.
Yeah, Dr. Samina.
Yeah, actually, like you said, regarding the transfer, referral from one ICTC to Lac Plus, direct referral. But I think it has to be channeled to the nodal ART center. If one ICTC wants to refer the patient to Lac Plus, that ICTC should refer the patient first to the nodal ART center, and the nodal ART center will link out the patient to Lac Plus.
I think this that's true, Dr. Samina. So for all on ART patients, that is the process. But I thought this question was pertaining to the Link ART Plus centers. Can you refer the patients directly for registration to an LAC Plus? So if I mean this again, like no, the flexibility would be with the SACs to decide how do they want to operationalize their Link ART Plus centers, and if a LAC Plus center is nearby to the patient. Then in that case, a nearby ICTC can do the referral to the LAC Plus center directly, but the catchment area has to be specifically decided by SACs, and then only this process has to be initiated.
Yeah, right. This is for the newly detected ICTCs.
Yes.
Okay. Thank you.
Because now we are moving towards same day or rapid ART initiation, and we don't want unnecessarily patients after detection should be going to multiple points just for the for their initial investigations and ART initiation. So if they are asymptomatic and can be initiated easily at an LAC Plus center, so I mean that is something which is encouraged. But having said that, I mean I'll just say that the decision for deciding the catchment area of LAC Plus would lie with the SACs, and it has to be done under the guidance of SACs.
Thank you.
Yeah, Arvind Singh sir, would you like to take ask your question now? You have raised your hand.
जी यस मैडम
जी सर
मैडम एक चीज पूछना था। मैं सेंट्रल जेल से बोल रहा हूँ, बनारस से
जी।
LAC स्थापित है हमारे यहाँ। बजट की रिगार्डिंग लेटर गया था सैक्स में
जी,
LAC की बजट की रिगार्डिंग। तो अभी तक जैसे कि मालूम हुआ कि नाको से प्रिजन सेटिंग के लिए बजट का गाइडलाइन अभी शायद नहीं हो पाया है।
रमेश सर, रेशु मैम, एनी थॉट्स ऑन दिस?
सर वो आपको सैक्स के साथ ही डिस्कस करना पड़ेगा कि क्या इसमें क्या इश्यूज हैं।
मैडम सैक्स को हमने हमारे यहाँ जेल से हमारे महोदय 3-4 बार लेटर भेजे हैं, अभी तक उसका
so we do have officials from NACO also here, so I would request them to please follow up with the UP SACs like what is the issue and please get it sorted.
प्रिजन सेटिंग मैडम एक रिक्वेस्ट है, प्रिजन सेटिंग प्रिजन सेटिंग के लिए LAC बजट की व्यवस्था हो जाए तो सुविधाजनक रहेगा।
ठीक है सर, आपका पॉइंट हमने ले लिया है एंड यूपी सैक्स के साथ इसको फॉलो करके ये देख नाको के स्टाफ जो यहाँ अवेलेबल है दे विल ट्राई टू सॉर्ट दिस इशू की इसको कैसे लिंक आरटी सेंटर बना सकते हैं।
LAC तो बना हुआ है मैडम, बजट के लिए
बजट का इशू है, ठीक है।
LAC बरेली में, बनारस में और वहाँ इलाहाबाद में बना हुआ है।
थैंक यू सो मच। सो
काम भी हो रहा है, LAC का बजट के लिए हम कर रहे हैं।
ठीक है, ये बात हम यूपी सैक्स के साथ क्लैरिफाई कर लेंगे।
लेटर भी यहाँ से गया था तो मैडम बात हुई
सिंह सर थोड़ा टाइम का इशू है सर, सो सॉरी। लेट्स टेक अप द नेक्स्ट क्वेश्चन प्लीज। एनी मोर क्वेश्चंस फ्रॉम द पार्टिसिपेंट्स? Ramesh sir, Reshu ma'am, I don't think there are any questions.
Thank you.
Thank you, sir.
Thank you so much.
Thank you, sir. Thank you, ma'am. Thank you, Puri sir, for joining the session. We can conclude the session now.